we have to trace the history of surgery in general. Laparoscopy was met with skepticism, just like people meet new technology or whatever, anything new in this life. So initially, people put a candle on the other side of the abdomen and put a scope to look at the bowel to see whether it's alive or dead. That was in the 1910. It was called cilioscopy. Cilio means the abdomen. The first laparoscopic procedure literally was done in 1981 in Germany when they did an appendectomy, and basically you can see that the surgeon was looking by himself, nobody else can see what he's doing, and he put trocars and he started to operate through these trocars. And we moved all the way until now we have what we call high definition cameras that can be coupled to the scope so everybody can see what we're doing, and then other hands can also join in the surgeon to help him in operating and doing what needs to be done. So that revolution changed bariatric procedures from 4,000 open procedures in 1992 to more than 500,000 procedures.
عملية التكميم تقوم على
So let me show you what a sleeve
عملية
is.
التكميم تقوم على وعادة فتح
I'm sorry that there is an Arabic narration, but basically I wanted to share with you. Here you can see we use keyhole and we go in, and in sleeve surgery all we do is we take the stomach, which is basically a reservoir, and we reduce that reservoir, maintaining the inlet and the outlet.
بالشبع بعد انتهاء
So
المعدة.
the
في عملية
complications
التكميم
of
بنصغر
sleep
المعدة
will
كأن
always
حجم
be related
الموزة
to the sleeve
الصغيرة،
itself.
وبالتالي يحصل
So
الشبع بسرعة
those
من
stable
خلال
lines could
اللقمتين،
leak.
وأيضا
That is
الأكل
the
بسبب ضيق المعدة
complication that is
يتحرك
now
ببطء،
rare, but
يتم هذا
still
الشبع
exists.
لفترة
So
طويلة
it
ما بين
depends
3
on
إلى
the
4
technology and
ساعات.
how good the
مثل ما
staples
نلاحظ
are.
هنا
And if there is
الأكل قاعد
interruption
يعدي
or basically
بصعوبة
a high
وببطء
pressure
من
system
المعدة.
where
شكرا.
if there is narrowing within that sleeve or a twist, increase the pressure and causes the leak. Also, we have the risk of bleeding because that staple line can bleed, and also because you separate the stomach from fat, so that also can bleed. Also, the major complication is dysphagia and inability to eat and drink. So by that I mean when the sleeve is crooked, is twisted, is what have you, then you will have difficulty in letting the food pass. And this is the major complication that we see nowadays, and that results in revisional surgery, the ones that you're interested in seeing the complications of. And part of the complication is you're creating a sleeve, an arrow tube. When it's a big stomach, it's not going to slide into the chest. But when it's a small stomach, there is a good chance that it will migrate into the chest and create a hiatal hernia. And hence, the term hiatal hernia is becoming more prevalent. In fact, almost some people think that up to 25% of sleeves may herniate, and probably 10% of them will cause problems for patients and require revisional surgery, which are the surgeries associated with higher complication rate. The next point to show is what is a bypass. A bypass is the classic, is called Roux-en-Y gastric bypass. You create a small pouch of the stomach, so it's a size almost like an ounce or 2 ounces in size, and then you bypass some of the intestine, the upper intestine, and link it to that stomach, and then create a side opening into that intestine that was brought up. So basically you have a food channel, the blue color, and in the other color you see the stomach, the intestine, the pancreas, the liver will secrete their secretions, and they'll meet the food at a later distance. So what controls weight loss is the size of that pouch, the size of the connection between the stomach and the small intestine, and also the length of each limb. So when people talk about the limbs, they say the limb in blue is basically what is called the Roux limb or the alimentary limb, which is the limb that receives the food from the stomach. The limb that does not receive food from the stomach, connected to the bypassed stomach, is called the biliopancreatic limb. Why is it called the biliopancreatic limb? Because it has bile and pancreatic juice. They come from the liver and the pancreas. So these juices that help digest the food will only meet the food down, so there's a second anastomosis the bottom of the picture, and that second anastomosis is where we start calling the bowel the common limb. So the common limb is when the two intestines meet, they create what is called the common limb. So in procedures, in order to decide on the amount of weight loss, we decide how much to bypass. And bypassing, we bypass the stomach and we bypass part of the intestine. So the length of the bypassed intestine and the size of the bypassed stomach determines weight loss. And this is what is called Roux-en-Y. Why? Because the two connections in the bottom creating the common limb is called Y. And then there's another procedure which is what is called the single anastomosis gastric bypass or mini gastric bypass. So it's a stomach, same thing, a pouch, but it's a longer pouch. And then you bring the intestine just as a loop and connect it up. So you also have a limb that is not seeing the food and a limb that is seeing the food. So the limb that sees the food is called the efferent because there is no common limb. And the limb that doesn't see the food is connected to the bypass stomach is called the afferent. So there is an afferent and an efferent. So there's only one anastomosis as opposed to two anastomoses in the Roux-en-Y gastric bypass. Hence, when we talk about complications of one anastomosis gastric bypass or mini gastric bypass, we talk about just one connection. So when we talk about, so now when we talk about the gastric bypass Roux-en-Y, there are two connections. In single anastomosis gastric bypass, there is one connection, or mini gastric bypass, there's one connection. So the complications are different, and hence this is why someone needs to understand that Roux-en-Y gastric bypass might have a higher immediate complications because a higher or more difficult procedure has two anastomoses, while a one anastomosis gastric bypass is likely to have complications in the future because of the length of the bowel that is bypassed, because it usually involves a much longer afferent limb that doesn't see food. There's another procedure that sometimes you may get to notice, where you cut the stomach and remove the bypassed part, and then the stomach is big, but then you bypass most of the intestine. That is called Scupinaro or BPD. So it is a malabsorptive procedure, which means hypoabsorptive, where the patient doesn't absorb enough nutrients because the mixing of food and the intestinal juice only happens at the very end, almost like a meter up to 2 meters of the small intestine. We'll see that. And that is a procedure. Those are the procedures that have a higher complication rate, long-term complication rates, and probably are almost relatively abandoned. And underneath this term is called, some of them call it BPD, some of them called it duodenal switch, which you can see in Canada, and also SADI or single osmosis duodenal ileostomy, because you're connecting the duodenum to the last part of the intestine. Having said those are the procedures, we can realize that no matter what the treatment is, including surgery, there is always regain, and that is part of the pathogenesis. So you will always regain, whether you use medication, whether you use surgery. There's always the chance of gaining the weight back if you wait long enough. However, the thought is that it's more likely that the gain will happen with treatments such as medication, such as temporary treatments, and some of the procedures, while some of the procedures like gastric bypass will have a sustainable effect due to the way it is constructed, because of the irreversibility of it, that even when you lose initially, for example, 50%, most patients, if they gain back, they may gain 20% or 30%, there will be a residual amount of weight that they have lost and they maintain it. One of the important topics is now for us is how do we choose the procedure, and trying to avoid long-term complications is important. Also trying to find the procedure with a good safety profile initially, easy to perform, and those are some examples of patients who had problems from gastric bypass. For example, this one is in aplastic anemia, the other one has hyperproteinemia, the third one has some form of skin lesions, and they're all related to those procedures. And the reason why I say is that you notice that procedures become popular, then people discover their complications, and then they reduce their dependence on them. Hence, the literature will keep on changing. There will always be gap in research, and hence, when we talk about the best treatment for diabetes, you will find that 10 years ago people thought it's RYGB, then they thought it was single anastomosis gastric bypass, then they thought it's sleeve, and now nobody knows what is the right procedure, because long-term complications and short-term complications matter for most people. So what matters for us in terms of complications? I'll tell you, what matters for us is sarcopenia. You don't want a patient to have bariatric surgery and then look frail and weak. And that is not something you can measure. You can see it. You can tell this patient had bariatric surgery. He doesn't look well. He looks thin, weak, tired. He's unable to function at the same strength as someone who is at the same weight as he is. Why? Because when they lose, whether they're males or females, if you look at those pictures, this is what we expect for a male when he ages. His muscles become less and his fat increases, and that is called loss of mass or loss of muscles, called sarcopenia. Sarcopenia in males or females would be accelerated by bariatric surgery if we're not careful in maintaining the muscle mass, whether by exercise or by giving them enough protein to sustain their muscle mass. So this is our greatest enemy, and hence their susceptibility to infection, inflammation, problems is higher if they're not well cared for. And sometimes we even end up with what is called sarcopenic obesity, and that means you can see the difference between a cross section on the thigh. This is a lean person and this is a sarcopenic person. You can see the amount of muscle is less in a sarcopenic patient, because though he lost weight and he's ideal, he's not like the same as the ideal person who has not lost weight. Why? Because he lost muscle mass along with his loss. Or also, sometimes you have a patient who lost weight but then gained weight back, and when he gained the weight he only gained fat, but when he lost fat and muscles. So those are the two situations that we have to be very careful about. And hence we have to talk about lean body mass and skeletal muscle loss, and ways to measure it would be excellent if we can develop, because we always use SICA, but which is basically the InBody, or a mechanism of measuring the impedance to electric flow in the human body to determine how much fat, water, and muscle mass is their body is composed of. When they lose weight, we try to use this machine. This machine depends on algorithms that are built into the machine, and they're really not accurate, so it does not really determine. It's a calculated method, and I think this needs AI to work on it and to identify a way of assessing truly and coming with normograms for what happens when you lose weight at a certain rate to the proportions of muscle versus water versus fat. That is something that we don't know about, especially when we talk about patients who are not monitored and losing from bariatric surgery. We have to understand that lean muscle mass loss is substantial, and especially in the first 3 months if no corrective action is done. And this is something that one can do in the clinic and say, well, oh yeah, you lost well, but unfortunately you lost a lot of muscle mass. There's an issue with you. We need to take care of things. So monitoring and helping and developing what I call a smart InBody assessment, better than the current InBody assessment, I think is important, and something that to tap into in the future. Somebody could make it his research subject. Just to show you an example, here we're talking about which procedures result in more muscle mass loss. This curve is comparing procedures. So the reference is, for example, RYGB as a reference, and you will notice that BPD loses more muscle mass than any other procedure and is detrimental to living. And in fact, the old band was also associated with muscle mass loss. The best two procedures when it comes to muscle mass loss are RYGB and sleeve. They have the lowest impact on muscles, but still they do affect the muscles. Now, when we talk about bariatric procedures in general, we talk about the 30-day complication rate, and this was a study in 2016 by Berger where he compared the procedures, and you can see that, like I told you earlier, RYGB has a higher complication rate in the first month compared to sleeve gastrectomy. Even as it drops, still RYGB will remain double that of a sleeve. However, having said that, RYGB is safer than an appendectomy or removal of the gallbladder, or cholecystectomy. Why? Because it's done by the best people. Usually the surgeons with dexterity and capability are the ones who will do bariatric surgery. So their advanced skills allow them to have lesser complications, while cholecystectomy and appendectomy, for example, is done by any general surgeon, regardless of their expertise and technical superiority. One of the things that we have to understand is that why people pay attention to bariatric surgery, because most of those patients walk to you and they want to lose weight. So a death in bariatric surgery is, how would I say it, it is reported usually in the news as frontline news. So for example, when Elvis Presley's daughter died after doing a bariatric procedure, it became public information. And this is why even our colleagues in different disciplines believe that this is a radical treatment. So though if you have an infertile lady and you do a sleeve on her, for example, she'll become fertile, yet the chairman of ASHRM, which is basically the society related to fertility, said, or reproductive medicine, said, yes, bariatric surgery is good, but it is only good for a few because it's such a radical treatment. Though it is safe, and we know about its safety profile, even our colleagues don't think it is safe enough. And this is why bariatric surgery is the only practice that decided to self-regulate itself and created what we call centers of excellence and accreditation programs for itself. So we have the IFSO accreditation, the International Federation of Surgery of Obesity, and the American Society of Metabolic and Bariatric Surgery, and the American College of Surgeons bariatric programs. And we in Saudi are working on developing an accreditation program to say who should do it and who shouldn't do it. We've gone a long way because we want to introduce what we call ERAS, or Enhanced Recovery After Bariatric Surgery, making it a day procedure. But how can we make it without having good monitoring when they go home? And hence, your project is very important. And I'll show you an example of how hesitant the bariatric surgeons are in making it ambulatory. In general surgery, what percentage of non-general surgery is ambulatory? Is about 63%. And what percentage of abdominal surgery, which is non-bariatric, so non-obesity related, is ambulatory? It's about 57%. But what percentage of bariatric surgery is ambulatory, which means, ambulatory means one day procedure? Less than 1%. Why? Because of articles such as the one you're seeing here, released in 2011, one day when John Morton said, well, ambulatory bariatric surgery were 13 times more likely to die. That was a scare for most people, and that they're likely to have 12 times more serious complications if you subject them to ambulatory surgery. Having said that, I'll tell you that literature changes over time, and today in the US most sleeves are done as ambulatory surgery because insurance wants it to happen. And most of the programs have decided to send patients with some monitoring devices that they can have with them in order to make sure that the surgeon can tap into, identify the vital signs, etc. And hence the AI project that you're working on of monitoring patients is there. Thank you.